Okay, so for this video, we're going to cover trisomy 18 and 13 together. Trisomy 18 is known as Edwards syndrome. Trisomy 13 is known as Patau syndrome. There's a lot of overlap and similarities with the two disorders. And we'll talk about trisomy 18 first. It's usually less severe than 13. 13 is usually the worst. Remember that we rank chromosomes. The reason they get the place in the lineup is the size. So it makes sense that 21 is milder than 18. It has fewer genes. 18 is milder than 13. It's bigger. Um, 13 is bigger, so it has more genetic material. Trisomy 18 affects females more than males, and all races are equally represented. Now, the reason it affects females is not because females are more likely to get it. The same non disjunction event or balanced translocation transmission from a balanced translocation carrier can happen to males and females, but females survive a lot of things that male fetuses don't. And that's even true when we talk about things like preterm delivery. It just seems, and make whatever snide remarks you want, it's just that at that point in development, females seem to have better survival rates. So more of them are born with trisomy 18 and more males are lost in utero. So the incidence is 1 in 3,000 to 5,000 births. Of those, 85% are considered full or mosaic non-apparent, at least we can say, trisomy 18s with the most severe symptoms. 15% have a mosaic pattern, some cells affected, some cells not, and partial, where only part of chromosome 18 is duplicated. And those are usually caused by your unbalanced translocations. There's a very high rate of miscarriage. True incidence hard to quantify because not everybody tests products of conception for chromosomal disorders. Sometimes it's just a loss and you mourn, but there's no testing that's done unless it's repetitive. Most of these babies that make it past the early embryonic period are stillborn. Live-born infants usually die within the first year, and even there we see a discrepancy between males and females. I'll show you on the next slide. There are many features. There's a lot of variation in this syndrome. And of course, again, they share variations in skin, hair, and eye color family members. So although they look different, there are similarities. And here's the copy of that extra chromosome 18. Clinical features, and here's some kids that have it, and they're just cute. That small strawberry-shaped head. You can see the head is wider here. Overall, it's small, but then the bottom of the face gets really tiny, so that they call it microagnetia, the small chin. Back of the head's a little bit longer. Now, here are the things that are really characteristic. So if you see them on ultrasound or somebody sees them on ultrasound, they know to look further. If you were assessing this baby, say somebody came in, no prenatal care, age 43, and you saw that this baby's hands were clenched in such a way that the first finger was overlapping the second, and the fourth finger was overlapping the third, that's a pretty big clue. You also notice this baby doesn't have good tone. There's a lot of lack of tone. See these rocker bottom feet? If you saw that, you would know something was wrong as well. Usually we do see a simian crease, but you have to open up these hands to find it. There are arch pattern fingerprints. That's really difficult to see on a brand new baby. An older kid, it's a little bit easier. There aren't many older kids with trisomy 18, but those kids, you could probably see that a little bit easier. Low set ears, again, check your ears, and the rocker bottom feet. And this has severe intellectual disability. These kids, if they make it past a year, they're almost always nonverbal. They may vocalize or make noise. They do interact with caregivers, but profound intellectual disability usually, and a lot of health issues. It's a hard diagnosis to give a parent. So, some associated health problems in trisomy 18, we have kidney malformations, heart malformations, the same kind. They tend to be a little bit more severe. So, with the Down syndrome, we were looking at maybe milder presentation. It does vary. But with these children, coarctation of the aorta is very serious. Still have our ASD, VSD. Omphalocele, which is like a protrusion of the organs through the abdomen. It's not quite gastroschisis, but you will see some sort of bulging out around that umbilical area. Chorioid plexus cysts. I have trouble with that word all the time. Brain cysts. They are fluid-filled cysts in the brain. Sometimes these are of no clinical significance. I got to be honest. When we first started seeing them pop up on the maternal fetal high risk list, we'd all go, "What is that?" And they would disappear later in pregnancy. Sometimes they're benign, but they are associated with a higher risk of trisomies 18 and 13 and 21. You can see facial defects. Cleft lip and palate are pretty common with this. You can see eye deformations. Microphthalmia is small eyeballs and ophthalmia. So when I was on orientation a long time ago, I had a nurse and she said, when you're checking a baby, and she was walking me through all the little things you have to look at, always look for the eyeballs. Make sure you see eyeballs. And I kind of looked at her like, okay. And she said, no, really, really, you have to look at the eyeballs. We had one here. We sent him home. We didn't know when the swelling went down, because babies are born with a lot of swelling in their faces because they're down in the birth canal for so long. Baby went home and the swelling in the eyelids went down. The mother discovered that the baby had no eyeballs. Now, I don't know how the pediatric provider missed this. They're supposed to do a red reflex, but maybe the baby was so swollen they didn't want to push it. I don't know, but it can happen. It is more common with trisomy 13, but in this case, it was a trisomy 18 that had anophthalmia. There are many times skeletal deformities. You already saw the rocker bottom feet, but sometimes we also have some problem with the vertebral column, fused vertebrae, scoliosis. Um, so you can see things like that. Esophageal atresia can be a feature of this syndrome. It's a blind pouch, so you can't feed this baby orally. It must have a G tube. Um, Higher incidence of inguinal, which is in the groin, and umbilical hernias. Poor suckling, failure to thrive. They are bad, bad, bad feeders. Usually that's due to the heart malformations. They are at higher risk if they survive their infancy for certain cancers. Wilms tumor, hepatoblastomas, they're liver cancers, and nephroblastomas, kidney cancers. They have many episodes of apnea, and there have been genitourinary defects like bifid scrotum, which happens when the scrotum sort of divides into two separate pouches. So it does affect a lot of different places of development. And it is considered relatively incompatible with life. We'll talk about that in a second. So there is testing for trisomy 18, similar to the testing for any other trisomy. CVS, amnio, NIPT, quad screen, first trimester screen. But women who aren't offered or who decline prenatal screening, usually the ultrasound really does tip them off. Once in a very great while, it'll be more of a surprise. And you kind of wonder what happened. How did it get this far? We had one like that maybe 4 years ago. And I don't know if the mother maybe didn't have prenatal care. But I'm not sure what A is supposed to be. I think that's the baby's head right there. Maybe somewhere in this photo, and I'm not seeing it, are the rocker bottom feet. But B definitely is choroid plexus cysts, those fluid filled cysts in the brain. And then C shows that tiny chin. And here's like that malformation of the eyes, that sort of strawberry shaped head where it's wider at the top. And if you were to measure the circumference, it would be smaller than gestational age would indicate. But here's the real kicker. You see that clenched hand with the overlapping fingers. Um, that tells you that you really need to follow that up. This woman is at high risk. And so things you could refer them to before you do invasive testing is a 3D or 4D ultrasound. If I would think Most maternal fetal providers, the ones that I know certainly, if they saw findings like this on an ultrasound, they would not waste their time with NIPT or quad screens. They would go straight to amniocentesis. And you can detect about 90% of cases between weeks 14 and 22. Um, and there are options that can be offered to those parents. And it's a good time to let them have some time for anticipatory grieving because most of those babies will not make it. This little guy is just as cute as can be. Most babies die in utero, 85%. Termination is an option that is offered to women with trisomy 18, um, and that can be done to prevent suffering of the newborn uh, or the child. It can be done to preserve the quality of life for the family. And whatever your feelings are on that, remember that, you are entitled to them, but your patient is also entitled to be free of them. Um, so, out of the survivors, the ones who are born and are breathing, 90% will not survive until the first birthday. Those rates may improve because there is a debate in the community about offering more invasive services. We're not automatically going to go to hospice all the time for these kids. So if they're offered things like heart surgery and surgery to correct facial clefts, um, some of these babies may survive a little bit longer. Females tend to have longer life expectancy than males, just like we talked about. Median life expectancy for males is about 1 to 2 months of age. Many won't make it through the first day. Females, 9 to 10 months of age. It's a big difference, but still before the first birthday. Occasionally, people with trisomy 18, including those who are thought to be full trisomy 18 because they don't have any apparent mosaicism, will live to adulthood. They will have profound disability. There is a woman, if you want to Google this, be my guest, Megan Hayes, and the pro-life community kind of puts her out there as um, a reason not to terminate pregnancies with known chromosomal anomalies. Um, and I'm not going to get into that discussion, but she is 40 years old. I say not apparent mosaicism because, again, you never really know. Maybe the brain cells are normal, but the skin cells aren't. Actually, I think she does live with a severe disability. But she has lived to the age of 42 if she hasn't passed on in the past 2 years, because all those articles came out in 2020. Ooh, all right. So trisomy 13. Let's see if there's a way back. I want to show you this picture. So trisomy 13, a lot of times similar to 18, but more severe generally. Okay. So this baby, like the nose never developed. We have a big bilateral cleft. It doesn't appear that this baby has any palate. So there's like an agenesis. The eyes are closely spaced. See these ear tags? Look at every baby for these, what they call pre-auricular tags. That's a soft finding for things. And then we have the oddly shaped head with the big jaw and the tiny chin and the microcephalic appearance. That's Patau syndrome, and it is 3 copies of chromosome 13. Affects females more often than males for the same reason that it happens in trisomy 18 that way, and that's because females tend to survive pregnancy more often than males. All races are equally affected. Incidence is rare, thankfully, 1 in 10,000 to 1 in 16,000 births. Most, 95%, miscarriage or stillborn. There's perinatal loss, and there's probably more. Because again, people don't always test the products of conception after a loss. Live-born infants usually die within the first year, 50% of those in the first month of life, 90% in the first year. Again, survival could improve with invasive treatment. So the things I tell you today might be updated when you are in practice. Most of these events are caused by meiotic disjunction, that sticky chromosome where you have 3 copies. Some cases attributable to mosaicism or inheritance from a Robertsonian translocation carrier, not really typical. Okay, so trisomy 13, some of the clinical features. Now, if you Google or search in any search engine for pictures of trisomy 13, I'm going to prepare you for the fact that some of them are shocking. Um, Trisomy 13 can be very disruptive to facial development. So when you see these pictures where the baby has no eyes, or the baby has one eye with a huge palpebral fissure and it's in the middle of the face and the nose is on top and the nose looks like a finger, there's a wide variation. You could have a baby just with a cleft lip who looks relatively normal, um, or you could have some really grotesque facial features. So we're looking at severe to profound intellectual disability. Usually there are other neurological problems, seizures, visual impairment, and deafness. Facial anomalies. Again, microophthalmia or anophthalmia. So either very small eyes or crying out loud. Sorry about that. Let me go back to where we were. My screen's just super touchy today. There we were. Clinical features. Okay. So small head, microcephalic. Uh, the chin is very small. The jaw can be larger, actually. Low set ears, cleft lip and palate, sometimes really severe disruption of facial features. We get extra fingers or toes, sometimes fusion, so polydactyly, sometimes syndactyly. There's a simian crease, there's rocker bottom feet. Very similar to 18, but more severe. Heart defects, apnea, brain and spinal cord abnormalities, polycystic kidney disease. Sometimes you have agenesis of the female reproductive system if the baby is a female, or you can get undescended testicles or a micropenis, or there's a lot of variations on that. You can have renal malformations, abnormal rotation of internal organs. The heart could have that rotation. So it's pretty serious. Now, the video that I showed you on the Robinsonian translocation said it was incompatible with life. Eh, you know, it depends. So here's a fetus that is. Sorry. Here's a fetus who's affected, and you can see there's a single eye. It's sort of in the middle of the face. The nose is absent. Here are the lips. I don't see a cleft. The ear is malformed, and it is probably low set, although I don't even know how you would assess that because the eye isn't where it's supposed to be. But the testing for trisomy 13 is similar to the testing for trisomies 21 and 18. You have NIPT, CBS amniocentesis, first trimester screening, and quad screening. But generally, even if mom has foregone other testing, she will probably get an ultrasound somewhere between 14 and 20 weeks, and you're going to see some features. Um, and that would lead you in the direction of talking to a genetic counselor, offering options for more specific testing. And in these cases where you see so many anomalies that would severely impact quality of life, sometimes they don't even bother with that. They'll just say, we have severe anomalies. What do you want to do with this pregnancy? And again, that is, a very personal decision. So treatment and care for babies with trisomies 13 and 18 varies depending on the presentation of the disorder. It targets the specific problems that child has. Here's a family, and they were offered comfort care. I'll talk about them in a minute. But when we look at treatment, we have the ethical debate there is quality of life versus length of life with invasive treatment. So yes, survival rates could improve with more invasive treatment. However, maybe you could ventilate these babies or give them a trach. Maybe you could correct the heart defects. However, the problem becomes is that you're putting that baby through painful procedures and they might not survive them. And you're putting the family through all of that too. So it's an important conversation to have with parents. Some parents want everything done no matter what, but that decreases the amount of time they have with that baby to hold it, to treat it like a real baby, to actually be a family. But it is an issue that may come back. And providers and parents feel differently. And usually it's the parent's choice when we talk about whether or not to instigate so-called heroic measures. So early intervention services, if this baby does survive, we can refer to PTOT speech for feeding. And a lot of it is just going to be targeting that low muscle tone, helping that baby feed effectively, maybe positioning, feeding and breathing support. You may need to provide extra calories because of the associated heart defects. In some cases, there will be surgical repairs. Palliative care is an option for a lot of families. This is care that keeps the baby comfortable, but doesn't necessarily prolong life. And so this mom is allowed to cuddle her baby, hold her baby. We want to support the family members, especially um, other children in the family who may not understand what's going on. Um, and that can be tricky when it's trisomy 13 and the facial features are severe. Do you let the younger siblings hold the baby, see the baby? It probably depends on where they are in development and how well you've prepared them for that. Um, but those are choices that the nurse can help the parent make. And if you work in a NICU and you see a baby with trisomy 13 or 18, you will be interacting with these parents and trying to help them. Now, this family here, I'm just going to kind of point them out. They felt that their child was not treated aggressively enough. I saw the other pictures that they posted, and the baby had looked like an umbilical line. It was an umbilical line, IV line, was on the heart monitor. Sorry, I'm going to back that up for a second. But they weren't feeding the baby. Now, it's hard to know what the specific features. They did not go into detail. It may be that the baby decompensated every time it fed. Maybe the baby had intestinal issues. It was trisomy 13. And baby lived 10 days. And they felt that they weren't taken seriously when they said, we want everything done. There probably wasn't much that could be done, and they were providing comfort care. Um, but it is important to identify what the patient understands and educate them on their options. And then a lot of times it really is the parents who have to make that decision. So that's sort of where that's at. Now, resources and support for people with 13 or 18. Of course, early intervention services, children's hospitals that specialize in genetic disorders. And there are things that are more specific, like the Chromosome 18 Registry and Research Society, the Trisomy 18 Foundation, chromosome disorder outreach. And then there are a few for all trisomies, Hope for Trisomy 13 and 18. I put a link there, and the ARC. All right, so we're going to cut this off here. It was long enough, and we'll pick up with the sex chromosome disorder.